A surprising number of PCI patients are not receiving aspirin before the procedure, despite the fact that there is a Class 1 recommendation for that. What are the implications of this? Well, I'm with Dr. Hitinder Gurm, University of Michigan Medical Center. The paper is December 3rd in JACC, and we're looking at the clinical outcomes of PCI performed without pre-procedural aspirin. I mean, this isn't the guidelines, correct?
It is the guidelines, and this is sort of something that we assume always happens, and our thought was this would be an infrequent problem, but we were shocked. I was honestly shocked that almost 7% of the patients were getting PCI without getting aspirin prior to the procedure. This is something that every interventionalist sort of knows that this should be done, and yet a small number of patients are slipping through and not getting aspirin. The second problem was that most of these patients did not have a contraindication. It wasn't like these were aspirin allergic patients where we should look for an alternative, but these were patients who could take aspirin, and most of them ended up getting aspirin afterwards. But 7% of the patients are not getting aspirin in today's world.
Now, what does that mean in terms of clinical outcomes?
Well, in our study, which is not a randomized trial, it's an observational study, so we can't claim causality, but the observation is very strong. Patients who did not get aspirin have a very high mortality. They have almost a 90% increased odds of mortality and 4 times the increased risk of stroke, and also signal that they might need more emergency bypass. So aspirin is a very good anti-thrombotic drug. We use it to inhibit platelets, and so it's not surprising that patients who are not on aspirin seem to have an increased risk of thrombotic complications.
Now, you were looking at something like 65,175 PCIs, about 20% STEMI, about twice that many NSTEMI. What was the database you were using to do this analysis?
So we are very fortunate in the state of Michigan that we have a collaborative, the Blue Cross Blue Shield of Michigan BMC2 collaborative, that includes every hospital in the state of Michigan other than the VA. We look at patients in hospital outcomes. The goal of this collaborative is to improve quality. So we looked at 2 years' worth of patients who underwent PCI in the state. So there's no exclusion. These are all comers, every consecutive case, and every patient in the state of Michigan.
So if the concept is these patients are just being overlooked as opposed to they simply should not get aspirin, what can we do to solve the problem?
I think as an interventionalist, I sort of always assume this is sort of one of our standard pre-procedural checklist things, and I always assumed somebody else was doing the checklist and making sure patients are getting aspirin. Now, we've included that as part of our pre-procedure timeout. Right. So it's part of the timeout, so we make sure that the patient's getting aspirin. I think once people become aware of the data, this problem should go away. It's just making sure the patients get aspirin. Sometimes patients are sicker. Patient comes in shock, patient has had a cardiac arrest. We can give them aspirin through an NG tube. We can give them aspirin rectally. We're making sure our emergency room recognizes that, and these patients are given aspirin in the emergency room.
So with a few exceptions, there should be certainly more patients who are receiving aspirin.
I totally agree. I think there may be less than 1% of patients who are truly aspirin allergic. And unless it's an emergency, in those cases we should desensitize them and then get them on aspirin, because we don't really have any data on what their long-term outcome is. It's an uncommon problem, but we don't really know what happens to them long-term, so it's better to solve the problem up front and then take the patient to the cath lab. But in almost all patients, we should be able to get them aspirin on board before we take them to the lab.
So for a look at this particular paper, it is the December 3rd issue of JACC. Gurm and colleagues, and please get back here for more coverage from the American Heart Association meeting. From CardioSource World News, I'm Rick McGuire.